So I'm going to talk a little about oral anticoagulants and toxicology. Uh, First and foremost, I'm not going to necessarily keep reiterating it, but call poison control. Here you can call 212 poisons as well, but throughout the entire country, 1-800-222-1222. So talking about oral anticoagulants, does this picture kind of make people think of anything? Okay, free range. Anything else? It's probably historically, it's no longer the most common oral anticoagulant, but historically it is. What is it? Sorry? Yeah. So warfarin was actually discovered through hemorrhaging cows. Throughout kind of northern United States and southern Canada, they started noticing that these cows that were grazing just kind of open pasture and on hay were, routine, non-terribly traumatic cow veterinary procedures, castrations, dehorning, were dying of just bleeding, of lack of hemostasis. It took quite a number of years, and then they kind of realized that it seemed to be related to silage made from sweet clover that had gotten kind of wet and become covered in some fungus that seemed to be the big difference between these cows and other cows. And it was in, Wisconsin that they ended up kind of isolating the compound as actually like di-4-hydroxycoumarin. But warfarin, which many of you might not know, is actually an acronym. So a nice thing, on various rotations that you could remind people, it actually stands for the Wisconsin Alumni Research Foundation, ARIN. So this class of molecules over here, without the hydroxy group, is a coumarin. And the part that actually is active that interferes with vitamin K, epoxide reductase, is this 4-hydroxy component. So a little bit of interesting historical knowledge. It actually has like a really nice, sweet, grassy smell, but it tastes really bitter. And it's found in cherry blossoms, vanilla, cinnamon, and a lot of things that we all love, but not the 4-hydroxy part. And it requires like the bacteria and fungus to convert it to the 4-hydroxy and become active in this way. So I kind of mentioned it really quickly. How does warfarin work? I think we all, intrinsically or extrinsically remember it because we get the PT, which measures the extrinsic pathway. And then you need to remember that it's interferes with vitamin K metabolism. And so it's over here at vitamin K epoxide reductase. And then this is vitamin K quinone hydroxyreductase, although some literature kind of just calls it vitamin K epoxide reductase. And then that interferes with 2, 7, 9, and 10. If you like mnemonics, which I'm not a big fan of, some people do 2 plus 7 equals 9, not 10, if that's helpful to you to remember the vitamin K dependent clotting factors, which certainly can come up. So what are these drugs found in? Well, on the left is a really old decon. It's actually no longer found in decon. There has been this transition to what's all the way on the right, Bertifacum, which are super warfarins, and actually decon now just contains ergocalciferol, which interferes with vitamin D. And then obviously Coumadin, which is the brand name. We use it very generically, but Coumadin is the brand name in warfarin. And that's where you're mostly finding it. Rat poison, or essentially rat poison for humans. But mice and rats have evolved their vitamin K epoxide reductase where normal warfarin does not work on them anymore. So they're maybe more evolved than us. So the management, if there is major bleeding, and both from the perspective of you're getting called in at a poison control center, the kid shows up to the pediatric ED or to the adult ED, if there's major bleeding, they come into the hospital, they get managed appropriately for that, and you're immediately going to plan for reversal. For somebody who just did, an overdose exposure. Now, if it's intentional, you come into the hospital automatically. Whether it's a superwarfarin, Coumadin, the person comes into the hospital for evaluation. Their INR might not be changed right away. And so people really need a 48-hour check, especially with the superwarfarins. Children are kind of unique. And I think we get a lot of calls in for people to be sent in by, unless you go into toxicology and work at a poison control center, you're not making the determination of whether or not they should come into the hospital, but you are receiving them in the hospital. So you do need to know how to manage a child who was exposed to, sorry, the run really made me sweaty apparently, because I was not planning to do it. People will show up to the hospital, mostly this is children, and the question is, do you get an INR? If they have no known previous exposure to a warfarin agent, then it's, a little different. So kids often are going for food, and you don't always know if this is the first time. Now, if you literally just put the Coumadin down, the superwarfarin down today, you just got prescribed your Coumadin, and the kid got into it and you saw them near it, they may or may not have ingested it. If there's no pattern of it, you have no risk that they did it before, then you might end up just keeping them home and doing a 48-hour watch, which is even controversial. At my poison center in New Jersey, Dr. Colello, who's a pediatric emergency medicine doctor, based on poison center data, which can be highly flawed, if you have no symptoms, the patient shouldn't come in, doesn't even need to get a 48-hour repeat check, don't need a baseline. If you don't think there's historical exposure. If you think there might be repeated exposure, you would send them in to get a baseline INR to see if they already are elevated. And then if there's no significant bleeding, you would discharge them home for a repeat 48-hour INR, either in the ED or preferably at their PMD's office. A lot of other people would advocate, even if you don't have a known exposure previously, and there is no major bleeding, you would still send them in for a 48-hour check. So don't be surprised if somebody gets sent into the ED saying, I called poison control, or my pediatrician said I should come in to get an INR today because they can't do it at home as an outpatient. You don't want these people to obviously fall and bleed, so you want to avoid injuries. The joke is, wrap them in bubble wrap, prevent them from having any major injury. That's the easiest thing, but not always doable. But for vitamin K, if they're long acting, you can consider, for vitamin K epoxide reductase inhibitors, you're going to be giving them vitamin K potentially, depending on the specific agent, but really prevent injuries. You can decontaminate them. Activated charcoal has been shown to work, but it, can be difficult for little kids. If the timing is greater than 2 hours, there's probably no reason to do it. If the person's super sick and hemorrhaging and you're intubating them, you might as well do it when they're tubed. But if they're super psychotic, there's not a huge motivation to make this happen, but it will almost always be recommended. So this is probably what's most important. What everybody wants to know is, when do you reverse the patient? When do you treat? Number one, follow your institutional guidelines. County, downstate both have institutional guidelines for this. It's a little different whether it's a superwarfarin or if it's somebody who's on Coumadin, warfarin, and requires anticoagulation versus somebody who doesn't. If their INR is normal, and this is talking about the 48-hour mark, or if you got baselines, if it's normal and there's repeated exposures, then you're not thinking so much about do you need to have that repeat, but you probably should still be getting that 48-hour. But when you're getting your INR that's maybe showing you whether or not you would think them to be super therapeutic, normal, nothing to do, maybe a repeat in 48 hours if you're getting the baseline. If it's greater than normal to 4.5, for warfarin needing AC, you don't want them to be fully reversed, right? They might have a prosthetic valve, they might have an AFib, and they might require further anticoagulation. So you're just going to omit their dose. Not on anticoagulation, well, you could fully reverse this person, but you don't do anything. You just prevent exposure to warfarin. And for superwarfarins, if it's ever elevated, These people need treatment for months often. These medications last for a really, really long time. And so them you're going to treat with oral vitamin K. Whether or not they need to be hospitalized for this or can be done as an outpatient is a complicated decision. And sometimes getting oral vitamin K is not so easy. If their dose is 4.6 to 10, no major bleeding, there's still not much to do. You're just omitting the dose. They're not on anticoagulation, again, nothing to do. Greater than 10, you're just giving them oral vitamin K, assuming there's no major bleeding. If there's major bleeding at any elevated INR, that's when we're giving vitamin K, which can be given orally. There's some issues with intravenous and anaphylactoid reactions, but it can be given sub-Q or intravenously as well. And you're probably giving 4-factor PCC, which includes those vitamin K dependent clotting factors. Major bleeding or life-threatening bleeds are especially ones that are not responding to your current hemostatic methods and are in areas that are like non-compressible sites, intracranial bleeds, internal bleeds, retroperitoneal. And most of these end up being traumatic. But if anybody has any bleeding, they are in the hospital, they're getting treated with vitamin K. A lot of what we know of how to treat superwarfarins comes from a case series out of Chicago. There's actually been another one that happened in Florida not that long ago, where people who were using synthetic cannabinoids were developing hematuria, other sites of bleeding, epistaxis, and were just presenting to the emergency department. They're like, what's going on? And on interviewing the patients, they realized that they were all smoking various synthetic cannabinoids and developing elevated INRs. And when they started looking into this, they realized that most of them, when they checked their blood levels, had elevated budoprutug levels, which is that superwarfarin I mentioned before. A few other ones, they never figured out if this was like a malicious adulterant, if this was an adulterant meant to enhance people getting high. I think the working theory was that they were probably had a big rat or mouse infestation wherever they were doing this, and somehow kind of contaminated all of their samples with budoprutug. And so people were then smoking it and getting really substantially elevated INRs. Almost all of them were greater than 10. There were 5 people that died, 4 from intracranial hemorrhages, 1 from a retroperitoneal bleed. And in this series, they actually had to work closely with the pharmaceutical companies. And I think they ended up at one point using veterinary vitamin K. And some people had to be hospitalized for extended periods of time because they just ran out of oral vitamin K to treat people. So a lot of people had these really long, prolonged hospital courses just to have access to vitamin K. And it's also in a patient population with limited access to care. And so some people were kept in hospitals or in rehab facilities to just administer oral vitamin K. So it can be a pretty major problem. This is moving on to the direct oral acting, direct oral anticoagulants. I was kind of always taught, and this is probably more of a pedantic thing for notes, to write DOAC, as in DOAC. Don't write NOAC, which was kind of the original term, which stood for novel oral anticoagulants. They're really not that novel anymore. But in notes, it can be confusing if somebody writes, under, your DVT prophylaxis writes NOAC, no AC. Are you saying that they don't need anticoagulation? Whereas if you write DOAC, direct oral anticoagulant, you're saying do AC. And so it just kind of helps get around a little bit of confusion. So the current more accepted term is DOAC, not NOAC, just when you're, talking to your peers. Dabigatran Pradaxa is the trade name. You will never see this anymore, just about. It was the kind of first direct oral anticoagulant that was developed and on market. And you can see over here, in 2011, it represented 31.3% of oral anticoagulants being prescribed by cardiologists, versus 68.7% being Coumadin warfarin. And you can see that as of 2017, I have to squint to read it at 3.8%. So nobody really prescribes this anymore. Mentioning it just because it does come up every now and then. But it is a direct thrombin inhibitor. There are some advantages to acting on only a single one of the clotting factors, which is kind of where we've moved towards today. But dabigatran, for a variety of reasons, it's a little longer acting. It seems to have slightly higher rates of bleeding risk, has just really fallen out of favor. So you will probably not see patients on dabigatran. I don't remember the last time I've seen or been called on one. They're people who have just been managed by their cardiologist since 2011, who haven't changed anything. It does have an antidote, which is actually a really, just to go to show how horrible our drug names are, the idarucizumab versus just Praxbind, again, Pradaxa, Praxbind. And it is a monoclonal antibody that will bind dabigatran and then prevent it from binding to a directly. So for these patients, PT and INR can actually have no correlation. PTT, APTT, up to a certain point seem to be pretty good, but their dose response curve kind of flattens out. And so you can't use it to say how anticoagulated somebody is. There's this Acarin ECT clotting time and a direct or dilute thrombin time that you can use, but those are not available anywhere. The Acarin clotting time is kind of cool because it's actually viper venom derived for everybody who went to the Bronx Zoo yesterday. If you can get a thrombin time, it's something to consider, but I don't think we have that available on either side of the street. An APTT, PTT is probably your best and only available option in most cases. Management, again, decontamination with anticoagulation. It has been shown to bind. If they're within 2 hours, it's not unreasonable for an acute ingestion. Whatever coags you have available, you're not going to probably have available the TT or ECT or DTT. It's kind of all follows that same. If there's critical bleeding, that's really when you need to reverse the person. If it's a massive overdose, you might consider reversing them. You can give idarucizumab, Praxbind, 5 grams IV. If you have it, we do have it at county. It's on non-formulary. So if somebody does happen to order it, you have to open up the non-formulary order and do it that way. I'm not sure about downstate. Otherwise, you're giving 4-factor PCC. The dosing, some literature will say 100 units per kg. Most people have moved to like a 25 to 50 or to a cap dose of 2,000 units, kind of for everybody. Gets 2,000 units and is a fixed dose and can repeat it. If you don't have 4-factor PCC, then FFP. The big problem with FFP is it is a lot of volume. So for some patients, it's not always the most appropriate treatment. And if there is no major, these act a lot shorter than warfarin. And so you don't necessarily need to treat them, if they have no major bleeding in the same way, or if it's not like a massive overdose that you expect your toxicokinetics to be totally different than your pharmacokinetics. So your 10A inhibitors, these have kind of become the most popular drugs at this point. And you can always identify them with the XA ban. The only, enoxaparin has an XA, but does not have a BAN in it. So it is not a direct 10A inhibitor. I think it's useful, but again, they still become word soup like rivaroxaban and doxaban, apixaban. But I think these are the ones that we see the most frequently. These are, as I said, direct 10A inhibitors. They should and do change the PT, but not in a reliable way that you can use for monitoring. And so there's not so much value in doing it. You can also get anti-10A levels, but it needs to be specifically set up for your specific 10A drug for it to truly be useful. Otherwise, an anti-10A level is really more just useful to say like plus or minus, like are they on something, are they not on something? We do have them at county. They come back in real time. They run on a blue top, but they're not they haven't been set up to be run for apixaban, rivaroxaban. They're more meant for patients who are on, I think, for like heparin drips instead of using PTTs for them. But you can send it. It's hard to interpret. You also need to know the timing. These are shorter acting. They're, within 8 hours, it's kind of, where you meet your peak, and then you start to worry about them a lot less. Is there an antidote? Well, the antidote is annexanet alpha. It's actually a decoy molecule, which is kind of cool. I think they took 10A and they switched a serine with an alanine, which is supposed to prevent this cleavage by prothrombin, and remove the catalytic activity, and they got rid of this GLA domain, which is supposed to prevent the anticoagulation activity of 10A. But the question is, like, does it actually work? I think this is the big debate. This is the most recent kind of final big study looking at annexanet alpha. And for anybody who listens to, say, like EMRA or EMA, you'll know Ken Milne, and he has these kind of like funny acronyms. You have like a POO, a patient-oriented outcome, which is kind of what you want every study to look at. You have a MOO and MOO, a monitor-oriented outcome, looking at, say, like blood pressure or a pulse ox. And then you have a LU, skip to my LU, which is a lab-oriented outcome. So this study, as well as every previous study on annexanet, looks at a LU. It looks at a lab-oriented outcome. They don't look at patient-oriented outcomes. They don't have a comparator group. So they're not comparing to patients who are getting 4-factor PCC, which is equally poorly studied and hard to know whether that is very effective. It does work in measured 10A activity. So it has been shown that patients who are on apixaban, endoxaban, or rivaroxaban, that if you check their 10A activity before, then after the administration of annexanet, that it will improve, that their 10A activity will be restored, but it has never been shown to actually improve any clinical outcome. It very likely works, but it's hard to fully say for an extremely expensive drug that you're going to give that for something with limited evidence that's purely lab oriented and has no real control or comparator. Kings County does not have annexanet. Downstate does. The process of being released at downstate at least used to be, and I don't think it's been changed, required you to actually call poison control, and they actually had to approve it for the pharmacy to release it. You don't need to go through all that for 4-factor PCC. And the Kings County official antidote guidelines and guidelines for the treatment of elevated or of bleeding in the setting of 10A inhibitor overdose or just 10A inhibitor use is to not give, it does not recommend annexanet and recommends 4-factor PCC. Those guidelines are as flawed as any humans who write them, but that is institutionally what we've decided. Management, again, it's pretty straightforward for all of them. Decon with anticoagulation, you are going to get those coags. Patients with large 10A inhibitor overdoses do have elevated INRs, but they don't, correlate well in any way with their level of anticoagulation. You can get a 10A if available. Again, it's really more of this like binary yes, no. Is the anti-10A activity elevated? If they have a life-threatening bleed, wherever you guys go, for everybody who's graduating, probably go with your institutional guidelines. The evidence does not yet support or require the use of annexanet, and not sure if it ever will. 4-factor PCC, again, the data also is really sparse and limited, and probably, whether or not that even works, but we'd have to do something. The use of 25 to 50 microunits per kg bolus is what a lot of people are recommending for 4-factor PCC. But again, most places here at Rutgers, based on, I think there's one Cochrane review that says that there seems to be equivalent outcomes of doing these 2,000 unit boluses. And for annexanet, again, it's a relatively, the 10A drugs are relatively short acting. And so if they're less than 8 hours, you're giving a higher dose of 800 milligrams. And if they're greater than 8 hours, you're going to be giving them a smaller dose of 400 milligrams. And just kind of going back to the Coumadin one, these patients are, you want them to be a fall risk. You don't want them to fall and hit their head and develop major bleedings later on. So summary, first and foremost, again, for overdoses, call PCC, call the Poison Control Center, get their recommendations of what to do and whether or not you need to reverse it. The patients with K2, I think, are the most interesting, but just because somebody says they use synthetic cannabinoids, you don't need to send an INR on every patient who shows up using synthetic cannabinoids. But if they do have significant bleeding and they do have use history, it would be, it's useful to check. Florida had an outbreak. Chicago had an outbreak. It's not an unheard of thing. People just do this stuff in their basement. For INRs that are, can be used to identify toxicity in the setting of the vitamin K epoxide reductase inhibitors. For superwarfarins, if there are elevated, you're discharging this person on oral vitamin K for an extended period of time if they have no significant bleeding, they have no psychiatric stuff or other medical things. And if they're otherwise, need to be hospitalized, they might be getting IV or sub-Q vitamin K. But you're not going to do 4-factor PCC or anything beyond vitamin K unless they have a major bleed. Dabigatran, you're probably never going to see one. It does have its own antidote, Craxbine, idarucizumab, word soup. You can treat it with PCC. It's kind of easy because 10A inhibitors you're going to probably in most settings treat the same way, possibly with Anexanet if available, and if that's what your institutional guidelines recommend. Any questions?